All right, hi everybody, and welcome to this episode of the Fellows Forum podcast. Today we're having this episode in honor of World Hospice and Palliative Care Day, which is occurring this year on October 12th. And I'm joined by two of our Fellows Forum members, Dr. Nida Khan and Dr. Richa Thakur. Thank you both so much for coming on today.
Thank you for having us.
To start off, I'd love to hear a little bit about basically an overview of what hospice and palliative care is, and why it's important to have this day to recognize it.
It's really a global initiative to increase awareness for palliative care, as there's so many institutions where, although they have palliative care services on site, a lot of the patients that really do need it just don't get access to it. And what's even more troublesome is that in the US, there's so many areas, especially at cancer centers, where more than like 50% of our patients at a comprehensive cancer center can't get access to palliative care. And that's just a very small minority of the patients we treat, whereas the vast majority of patients in the community still don't have this. And, while it's bad in the US, one thing that really bothers me too is that there's just so much stigma between palliative care and hospice, and it's often even worse in other countries, not just for stigma, but also the amount of resources required and for appropriate palliative care interventions and access for patients to resources. And I think like taking a day like October 12th for specifically these two is a really great way to bring more awareness to both palliative care and also hospice and what it can do for our patients.
Yeah, I agree completely. And I think to add to that, I think having this day in particular is super important because it also marks almost 10 years since the World Health Assembly passed a resolution that, and I think it's probably one of the only standalone palliative care resolutions that really emphasize the importance of palliative care as a human right and something that needs to be a part of patients' health and patients' health care. So that's one thing that it seeks to recognize and that this day specifically seeks to recognize. And then the other, I think, vital component is also to recognize that palliative care needs to start to be seen as in addition to a patient's treatment or a patient's medical course instead of despite their treatment. So it's really as an adjunct, a supportive care. And I think not only in things like cancer or malignancies, but also in things like advanced heart failure, late stage COPD, and really chronic conditions that do tend to have kind of a progressive course through patients' timeline. And then also the other thing, and that Richa also mentioned, is that not only nationally, but also to emphasize the importance of this globally. So access to palliative care, we already see, funding issues, we see access issues in the United States, but this is even exemplified in some parts of the world, right? So to also raise global awareness regarding that.
Yeah, really true. I think one really good point that you bring up is palliative care is really common in care with like disease modifying treatment, no matter what it is, right? For example, if a patient has a heart failure exacerbation, not only do you treat, the hypertension, the hyperlipidemia, you also give Lasix. Right? And Lasix is both like treatable for the exacerbation, but it's also palliative. It helps patients get rid of their swelling, breathe better. And I think one thing that really frustrates me is people feeling that they have to choose one or the other. But to be honest, patients should have the option to have both.
Yep. Yeah, I agree completely. And I think this is all part of the same idea that it's understood as a part of longitudinal care of the patient, as they kind of live through and as they manage their disease process. And really that a main and huge focus of palliative care is symptom management. And so like you just said, things like Lasix, which traditionally are used in heart failure management, are also important for symptom management. So things like that. The other thing I do want to also kind of emphasize is that the day also hopes to provide education regarding this, both nationally and globally, not only through fundraising events, but also through educational seminars. And we do see a lot of that happening around this time. And then the other thing, Richa, I wanted to bring up was also access to medications and how difficult that can be, and specifically symptom symptom tailored medication. So things like controlled substances. Um, Access to that is super difficult, not only in the United States, just because there's a lot of stigma around controlled substances. We know that obviously they're helpful, but how do patients access that? And then also how this is even worse on the global level. Yeah.
Those are really good points. Maybe we should start with the education piece and then work through some of them. Um, I think one of the things I just wish wasn't an issue so much anymore, although it constantly is anytime you bring palliative care, is the misconception with hospice.
Mhm.
And I always struggle to explain this not only to patients, but also other clinicians sometimes, that it's a huge spectrum of cases, and hospice isn't only palliative care. It's really an insurance benefit that patients get, and they really only qualify for it if their life expectancy is less than 6 months.
Mhm.
But palliative care is something that starts at diagnosis of a sick illness, not just towards the end stages of the illness. What
Yeah.
about you?
Yeah, I agree completely. And I think a part of education would be to really reinforce kind of the evidence-based approaches we have regarding this, right? So we have trials, we have research that shows early introduction of palliative care and then also introduction of hospice helps with better quality of life scores, better mood scores, and also can help with life expectancy and prolonging it because your symptoms are better managed, right? And you also have that support. So when you're enrolled in something like hospice, which you said it's a Medicare benefit, but also it you have this kind of continual, um, you know, weekly, even daily, hospice RNs, hospice social workers, you have a hospice physician that is available to you to meet your symptom needs. And because of that, because our quality life scores improve, because our mood scores improve, your life expectancy may also be longer. And then I think the other part of that is also to educate that we have a lot of patients that graduate out of hospice too, right? And I don't know about you, Richa, but when I was on some of my hospice rotations, a lot of folks were like, we were like, oh, hey, you know what, you're ready to graduate out of hospice. And I know we just love this so much because we get so much support, right? So in some ways, I think educating about that, that hospice doesn't mean that you're not getting treatment. We're just changing the direction of treatment to manage more your symptoms.
I couldn't agree more. I mean, there's definitely several randomized controlled trials. The most famous one is the Jennifer Temmel study with non-small cell, like advanced lung cancer. And
Mhm.
there's that does show an improvement in overall survival with early palliative care. With other cancers, we don't have as much evidence on overall survival, but significantly in other domains. So obviously, both of us are huge proponents of this.
Mhm.
I think the other thing that I wish every physician had to do would be a hospice rotation. That was my favorite part of my palliative care fellowship because so many times you explain it, but when you actually have to get in a car with a chaplain and drive to a patient's house and see what a chaplain or a social worker does when they visit these patients and what they offer the patients at their own home, it's incredible. And it just makes it so much easier to see why hospice is so great. And
Okay,
it's
great.
much easier to have that discussion with your patients.
I agree. I definitely do wish it was a part of our healthcare training, not only in physicians, but really anyone who's involved with patients who have kind of chronic progressive diseases. Just because, as you said before, you have chaplaincy, you have social workers, you have hospice RNs, you have physicians who they've really become a part of the patient's lives. Become a part of their community, and they really do really great, amazing work for these patients. And so, in some ways, to change what's like quote unquote like the bad rap like surrounding hospice, I think it would be really helpful to educate on that and have that option open to people and healthcare providers. Yeah.
Yeah, I think the other thing we also don't really often bring up with patients and their family is the bereavement support too patients get from hospice. And it usually, depending on the site, it usually covers like social and supportive services for up to a year. So that's for like anniversaries, birthdays, anything, because that first year after a loved one dies is so tough on their caregivers. And oftentimes we really focus on just the patient, but the caregivers are also a big part of it. And that's one really huge aspect that I think palliative care and also hospice programs address more that often get left to the side with traditional
Yeah,
treatment.
I agree completely, Rich. I'm so glad you brought that up because we have multiple patients and yeah, I would go on my hospice rotation and the patients, nearing the end of life and we're still there coming in to talk to the caregivers who are, obviously we're a vital part of the patient's lives, but also who we saw, weekly, 2 times weekly, 3 times weekly, however many times we were coming to their home. And then also there's other services, right? So hospice also offers things like pet therapy, massage therapy. We also have volunteer services where it's just really like a social companion. If you're, just some companionship that is always needed. When the caregiver can't be there, right? So there's all these services that are just part of hospice beyond what you traditionally may think of it.
And I think another part too is that these services are definitely part of hospice, but there's versions of these services too for either an outpatient or an inpatient palliative care consult too. So, like one thing I'm always surprised about is patients tell me it's really hard to tell their children or what to do with their kids. And a lot of oncologists, or I mean, even other specialists that need a palliative physician, don't think to call a child life specialist, for example. And that's a really useful resource that patients should have access to. But unfortunately, just with lack of access at a lot of sites or just knowledge even to ask for these things is limited. And one of the great things about a day like this today is it's a nice way to at least raise awareness, not only for palliative care physicians, but also the entire team, because it's a pretty resource heavy team and a palliative care approach is a very interdisciplinary network. And that way, sometimes you don't need one person in this one moment, but you might need them later. And at least knowing what else you have access to is helpful.
Yeah, I agree completely. And I'm also glad you brought that up. Palliative care is so interdisciplinary. We work closely across disciplines, things like the child life specialists, the chaplains, massage therapists, social workers, all of those, just because that's the nature of our field. I also think it's also very dependent on institution. It's dependent on where you are. It's dependent on, a lot of other factors. And so with having this day in particular, you learn from what else is out there. So, just in speaking with other palliative care specialists, you learn what's available at their institution, how they're doing things, just so you can better your own management and how you do things where you're at. So I think just to raise awareness regarding that and what else is out there and the possibilities for your own program is also super important. And then Richa, if it's okay, I think it's also just because this is World Hospice and Palliative Care Day, how are things different, on the global level, right? So we
That's a really good
have,
point.
exactly, yeah. So we have, I can only speak to, my experiences in the places where I've trained and I'm sure you can only speak to where you've trained and where you've worked. But you can read about, you can talk to palliative care specialists from places all over the globe and how their experiences are completely different. And so I do want to bring up, so I did, work and I did a rotation in Uganda in palliative care, and the amount of resources that are available to me here versus in Uganda are completely different, right? So this World Hospice Palliative Care Day also is there to kind of highlight access issues, how things are different on the global level. And one thing I do want to bring up again, and I know I mentioned this, is that access to medications, right? And so when I was doing my rotation in Uganda, the only real symptom management med we had for pain besides your, routine Tylenol was morphine. And even that was hard to come by. It was super limited. And then maybe tramadol, which, some people don't really like to use. I know I don't like to use it that much, but really that's all we could use. And there was no really long acting formulation that we had at our fingertips, right? So that just goes to show how kind of spoiled we are here at our institutions with the availability of symptom meds that we have, right? And so I think this day also seeks to bring up lack of access to vital symptom management medications, to pain medications. And with the World Health Assembly's kind of resolution that palliation is a human right, so how do we work towards making it a human right to everyone?
That is so true. And I mean, what frustrates me too is that the World Health Organization has a list of essential meds that are basically absolutely mandatory to really take care of patients. And dying in comfort should be all right. At least that's what I believe. And having to suffer through pain is awful. It's something I would never wish upon, but there's only so much you can do when all you're really using is morphine. You really do need long-acting opioids, especially in end-of-life situations. And it's tough when you really just have one, because what happens when there's a side effect to it, there's a limit to what you can do. You can't really do any of your opioid rotations, and that's a pretty big thing on a global scale. And I I mean, I wish like people also realized how much of an issue that is in even just the US too. For example, like the number of times I've sent an oxycodone prescription or a morphine prescription only to have the pharmacy say they don't have it in stock, or that their insurance doesn't cover it, is really heartbreaking.
I agree. I think it's difficult as it is with the way that, the healthcare system set up here with the, the countless prior auths and whatnot that we have to deal with. And then on top of that, availability, going through insurance companies, and then when you look at it on the global level, it's kind of exemplified. And I'm just like in awe in how these healthcare providers, these palliative providers in other countries, how they're even able to manage it really.
Right. I've only read about these struggles, so I never actually trained abroad. All of my training post medical school was in New York. So I was,
Yeah.
even though we have our own problems, I was pretty fortunate with the access we had to palliative care. What was it like for like just being in Uganda for you?
It was, it was difficult because we have a lot of patients who present to us at the tail end of their disease process just because of the lack of routine healthcare, and people who are, if we had routine screening, you know, uh, via, age, via guidelines, if those were done, a lot of these malignancies could have been caught, right? And so when they presented to us, a lot of them were at advanced stage, late stage, end stage kind of malignancies, cancers, that at that point, there really was only the palliation route. And so um, then when you're focusing on the palliation route, and then to only really have only so many medications available to you, it makes it really difficult. It makes it really hard, right? Um, and then speaking from a purely cancer standpoint, where I was at, there was no cancer center. The closest cancer center was about 300 to 400 miles away. And so then you're in the spot of, finding fundraising for these patients to go to this cancer center 300, 400 miles away to have a consultation with the only oncologist in a 500-mile radius, for them to probably say the same thing, that this is unstaged and there's nothing I can do, right? And so you're in the palliative route, and then even then we don't have the right symptom meds. So it was difficult. I learned a lot from it, and I think there's a lot to learn from it. I learned a lot, but there's also a long way to go. And I think that this day really highlights that, right? Just so we're talking also like the global level and highlighting the need and access to palliative
And
care.
even if like there were treatments offered, 300 miles is a long way for a patient to go. So
Mhm.
even with patients that potentially might have had curative treatment, if they can't get the finances to physically get to the center, you're also
Mhm.
forced to really not be able to treat them and let a disease take its course untreated. And that sounds really heartbreaking.
Yeah, it was. And I think really just to keep in mind that obviously we're speaking from like a privileged position. And
Mhm.
so I can like, I I just like, my heart goes out to those patients, to those healthcare providers, to those palliative specialists, just to anyone who kind of works in that setting or is a patient in that setting, because it's hard. It can be difficult. Yeah.
I mean, I guess one thing I can speak to, at least growing up with like a little bit in India, I mostly grew up in Texas, but with my extended family in India, there's
Mhm.
lots of countries in the world too where even if you have access to palliative care services, meaning you're in a big city, which the vast majority of the country won't be, even
Mhm.
near a cancer center, there's a lot of stigma that's often even worse. And oftentimes, dying with intensive therapy is seen as a way to express love to someone.
Mhm.
Whereas in my completely biased opinion, I think it's probably the opposite.
Right.
Um, and that stigma is very, very hard to undo. And even if the patient's family members might not want futile, unnecessary treatment, there's also a huge social component in a lot of areas where they feel that their neighbors or their extended family will look poorly upon them if they withdraw care.
Yeah, and I think this is something that we experience, home side in the States, and it's also, abroad, right? So there's different connotations, as both you and I know, that come with hospice and palliative care, and then also speaking about both of those things within like a cultural competent context, within a social context, within a regional context, just really changes the whole meaning of things. And I think also educating on that is super important, and that's also what this day hopes to recognize. And also not only educating patients but also educating providers, right, to the importance of social competency, cultural competency, and speaking about this within that context. So that's a great point, and I'm really glad you brought that up, Risha. Mhm.
And I mean, I think this is really tricky because a lot of times people make assumptions, but every religion, every faith, every socioeconomic group has such a vast spectrum of things.
Mhm.
And sometimes I think it's very hard to figure out what to do. And I would say my one advice is maybe just ask the patients. And usually what I do is I don't even bring, like, for example, if a patient comes in with a hijab and I think they're probably like of the Islamic faith or like rosary beads, I would never actually ask about the faith itself. But the way I would ask the question to the patient is, what do you think I should know about your beliefs so that I can be a better doctor for you or I can take care of your care? And I think by not calling it out, by giving patients and their families an opportunity to speak, it also helps build rapport.
Mhm.
And it also comes from like the patients will perceive it as a way of you're trying to understand and partner with them.
Mhm.
And I think that's something we often don't really get taught very much in our classic training.
Yeah, I agree completely. And I love the way you phrase that. I think I'm going to steal it for future for future meetings with patients and their families. But yeah, definitely kind of phrasing it that way, I think really helps. It makes the patient and their family as a part of their decision making, makes them feel like part, they have some agency in that, right? And that also that we're seeking to understand them, because in our field, in the palliative care field, we're one of the few, medical specialists that even take the time to ask about those things, right? And so that's what makes a person who they are. It can be a huge part of their life. So asking that and seeking to understand them can also really help not only build rapport, as you said, but then also down the line when it comes to making difficult, challenging decisions. Having that rapport is important, but also you'll get a better idea of why patients and their families are leaning a certain way, um, rather than any other way. So that's super important, Richa, and I'm so glad you brought that up. Yeah.
Um, I think one other thing we should probably also touch on is maybe training for physicians, at least in the US. So
Yeah.
I did an untraditional road, but a traditional like hospice and palliative fellowship one way, and then went back to do like a hematology and oncology fellowship. But neither your path was a little different because you took one of the new combined fellowship programs. So
Yeah.
I think, what has your experience been like so far?
Yeah, yeah. And before I start, I'm gonna say all credit to Richa, because I remember when I was first thinking about palliative care, um, I actually reached out to you and because I knew that you did palliative care, and I asked about your experience with it because we were both interested in pursuing oncology after the fact, but you were one of the first people that kind of inspired me to do palliative. So I wanted to thank you for that. But then also, yeah, I can definitely speak about the combined program. So I'm part of a combined medical oncology and palliative care program. And there are now, I think, I could be wrong, but maybe I think 6 or 7 programs in the country now that offer this combined program. They offer hematology, medical oncology, and palliative combined, or medical oncology and palliative combined, depending on the program. And it's really a truncated way to get formal training in both specialties, and then also have the ability to have board eligibility in both by the time you graduate. So it's kind of like an accelerated pathway in that way, and it's been great. Yeah, and I've really loved my experience in it. I feel like I've learned a lot. So yeah.
Do you get boarded in hematology and medical oncology and palliative, or two of the three?
So my program here at Ohio State, where I am, is medical oncology and palliative. Some of the other programs that offer the combined also add on an extra year for the hematology.
Oh, so it ends up being 4 years, right? Or 3?
So so for me, it's actually 2 years because I'm not doing the hematology portion. For people in the other the other programs that offer the hematology, for them it's 3 years. So to do heme, med onc, and palliative. So.
I see. So for people that want the traditional palliative care route, that fellowship is usually just 1 year. For a lot of palliative physicians will go back and do a second fellowship. Geriatrics is usually the most common, but it's also not really unheard of to have physicians board in critical care, or also hematology and oncology too.
Yeah, yeah. And with palliative care in general, because it is a 1-year fellowship, as you mentioned, you get, folks from really all residencies, because palliative care really can apply to any field. So I've had folks from neurology, PM&R, emergency medicine, some surgery specialties, general surgery. So really anyone and everyone who has training in really any medical specialty does seek to do a palliative care fellowship, just because of how beneficial it is for your training.
I think one other thing people should know is, especially if you're an attending, it's very hard to go back to a fellow salary. A lot of programs will let you do a part-time hybrid palliative care fellowship too. So basically you work half the time as a fellow, half the time as an attending. So the pay is usually a little bit better than a fellow salary, but at least this way you can go back to your training, but the drastic change isn't as hard.
Yeah, there's a lot of options out there. If anyone who's listening to this does want to do a palliative care fellowship, and there's a lot out there for you to get that formal training.
Yeah, I will say that was the best year of my life. I will never regret that year. So if you're considering it, you should definitely apply.
I agree completely. Well, Richa, I think that really brings us to all I have for the World Hospice and Palliative Care Day, unless you have anything else to add.
I mean, I think the only other thing I have is if anybody else wants to get some more information on how to do palliative care, CAPC has some really great modules that you can do on your free time, because we have so much anyway. But besides that, thanks for having us. It was so nice talking to you too.
Yeah, likewise. Thank you.